Boa tarde a todos e todas que nos ouvem, nos assistem pelo YouTube. Pedimos desculpas pelo pequeno atraso, tivemos um probleminha técnico aqui em relação à transmissão, mas agradecemos a paciência de todos que estão aí nos acompanhando pelo YouTube. Sejam todos muito bem-vindos à nossa reunião científica do mês de setembro da Câmara de Pós-Graduação em Pesquisa da Escola Paulista de Enfermagem. Hoje nós temos a honra aqui de receber conosco uma palestrante internacional, a doutora Mandi Pratt-Chapman, que é professora associada do Departamento de Medicina da Escola de Medicina e Ciências da Saúde da George Washington University. A professora Mandi está conosco aqui na Escola Paulista de Enfermagem por meio de uma missão da seguinte, do qual nós já gostaríamos de deixar aqui o registro do nosso agradecimento à CAPES por essa possibilidade de internacionalização do nosso programa. A professora veio justamente a convite dos professores aqui da nossa escola, professores do Departamento de Enfermagem Clínica e Cirúrgica, e gostaríamos de agradecer especialmente a professora Edivane Birello, que tem recepcionado a professora Mandi, e também a pós-graduanda Tamara, que é orientada da professora Edivane. Agradecemos a todos e vamos dar início. Passo então a palavra para a doutora Mandi.
All right. Okay. I hope you can hear me. Can you hear me okay? The people who are online.
Todos conseguem ouvir bem? Caso não consigam, nos avisem.
Okay. So I know maybe, I think 2 or 3 words in Portuguese now. So I didn't understand much of what he said. I heard my name. I'm happy to be here. I have a lot of slides, so if there are too many, we can stop whenever you want and talk about whatever you'd like. And I was telling Tamara and Ivane, I'm not nervous, but I'm aware that I'm coming from a US perspective. And so everything I say is from what I know from where I am. And I would appreciate the conversation about what is the same, what's different, and what applies. So,
Saiu a apresentação.
What did I do? Oh, yeah, okay. These are I'm starting with my pronouns, she and her. I like to start any talk I do with learning objectives just because I do so much education and it's helpful to say what we're going to cover. So I'll talk about social determinants of health and health equity, the importance of intersectionality, and I use the term SGM, which I should have changed, but at the National Institutes of Health in the US, they've used SGM as sexual and gender minorities as the term. So even though LGBT people don't use that term in research and clinical care, we often use that term. So that's why it says SGM. Oh, sorry. I'll already went through that. So I don't know that I need to go through the basics of the terminology. Probably everybody knows. Lesbian, gay, bisexual, transgender, we are intersex. Some people haven't heard the term intersex though. So intersex, in case anybody is not familiar with that term, there are individuals that have both male and female typical parts or biological or chromosomal characteristics. And so a lot of times people have heard the word lesbian, gay, bisexual, transgender, sometimes queer, but intersex might be new. And this slide is just to say that all of those terms are limited because culturally there are different terms based on geography, based on cultures. So in American Samoa, I have a colleague there, people who are transgender are referred to as fa'afine. So this is just to point out that those terms are limited and they're kind of when we're talking about LGBT people, and when I use the term SGM, it's meant to be more inclusive than limited. And is intersectionality a term that you have used or use here? Is that yeah? So the idea is thinking about the power that we have, where we have power and where we have vulnerability. And I present this content to a lot of different audiences, and I always encourage folks to think about in what places in their life they have power and where they might feel more vulnerable, and how that affects your health, because this is really at the root of most of what I'm talking about, is kind of where people fit socially and where they have power and where they don't have power. And this is something also, when we're talking about social determinants of health or social situations that lead to adverse health outcomes, this is because stress is a laboratory of disease, right? So stress doesn't cause cancer, but it creates our system is more vulnerable, right, to cancer. So when we talk about social determinants of health, we're talking about economic stability, neighborhoods and physical environment, education, food, social connectedness and support, and then healthcare system access. So even before someone gets to the healthcare system, we think about 80% of our health is influenced by these other factors. Did I do the wrong arrow?
No, I made it slow.
It's loading, okay.
Yeah, because you're presenting.
It's big, yeah.
Yeah. Just.
If you want me to keep talking, I could grab my computer and just see what I have next on my slide, or I can wait. Okay, it's okay.
Do you want to go?
Yeah, sure. Just in case.
Yes.
I don't need notes, but I do need prompts. I need to know what my past self was telling my present self to say.
Okay, now it's come back.
Oh, it's because there's animation, I think, to this one. So there's a lot of data. So on this slide, I was just talking about how for sexual and gender minority people, some of the things for people in the room, I can show you my slide, but homelessness, income differences, insurance differences, food insecurity and access to care might be more pressing than getting a cancer screening or so I'm going to try to advance the slide and see if it goes. It probably didn't like all the animation I have on this slide. Oh, there we go. So homelessness, income, insurance, food, and access to care. Okay. So minority stress is really chronically high levels of stress faced by any population that experiences interpersonal. It's weird to say interpersonal stigma. I think this just changed on YouTube. Whoops. Okay, like interpersonal prejudice or stigma between people, internalized homophobia, experiences of discrimination. Social support is a factor that influences whether the level of resiliency, and then socioeconomic status. We were talking about differences in your public and private systems and access to how quickly care is provided, and I think that's true regardless of a lot of different complex differences across settings. I mean, that's certainly true in the US as well. It's in a different way. What did I do wrong here? Let's see. Perfect. Okay. So lesbian, gay, and bisexual respondents in this study indicated when they were in US states without protective policies, they were 5 times more likely to have 2 or more mental health challenges. People who experienced prejudice-related major life events were 3 times more serious to have a physical health issue. And people who lived in communities with high anti-gay prejudice were more likely to die 12 years earlier. So along with these statistics, 70% of transgender and gender non-conforming people have experienced harassment in public restrooms, again, US context, so I'd love to hear how that's alike or different here. And about 60% have avoided a restroom due to fear of harassment. And so when people experience these ongoing stressors day in and day out, it can elicit a traumatic stress response, and it can influence behavioral health risk factors, and depending on social supports and other systems supports, impact can be different. So some of the things that we can do when we're screening for minority stress is to ask patients or study participants, how comfortable do you feel navigating the world with the identities you've told me about? Have you experienced discrimination or harassment? Do you feel like you need to conceal your identity? And then also, how do you cope with things? So you can tap into, how resiliency, where's your support and what brings you joy? Those are some things on the positive side to help people identify support. So bias is something that I work on a lot in the US, implicit bias. And, implicit bias is really a tendency or inclination that results in judgment without question. So it's an automatic response, and we need these shortcuts in order to interact with our world. So it really, it's kind of how we act without awareness, intention, or control, which often is different from what we potentially value or believe, but these are shortcuts that we've learned over time. And so unconscious bias helps us protect against harm, and it's influenced by experiences and media portrayals, cultural conditioning, upbringing, and we all have biases. And so part of one of my studies, I'm not talking about in this lecture, but that I talked about this morning on a virtual lecture, was training oncologists in America around implicit bias, knowing that our systems are set up to privilege certain populations, and knowing and just being aware of this can be part of trying to make those systems better. Trauma can come from directly experiencing or witnessing something very significant or serious, like threatened death or actual death, serious injury or violence, or learning about someone that you care about very much who's been through that, or being repeatedly exposed to details about those kinds of things. And I'm not going to go through all of these statistics, but over 80% of LGBT youth have reported verbal harassment in school. And for older adults, over about 65% have indicated that they've had some kind of violence, emotional or physical, 40% physical. So all of these things are precursors and create a situation of trauma. So when we're talking about LGBT affirming care, we're really talking about trauma-informed care, right? So like care that doesn't reinforce the trauma and acknowledges it, recognizes symptoms of trauma, and tries to prevent additional trauma. And so ways to provide trauma-informed care by embracing individuals' identity, validating feelings and not dismissing them, and acknowledging that while we don't have great scientific data all the time, because we don't collect sexual orientation and gender identity in all of our studies, that we are obligated to act in an ethical manner using what we do know. So moving more directly into risk reduction and affirming environments, these are some just environmental suggestions: having non-discrimination policies that specifically indicate protections based on sexual orientation and gender identity. Rainbows are just kind of a universal sign that queer people kind of know means that you're friendly. Brochures, posters. The HRC Healthcare Equality Index is the Human Rights Campaign. It's an opt-in survey that U.S. institutions can participate in to show if they're doing certain things like training or outreach or data collection, to say we're trying to do a good job in this area. It's not required. It's something an institution can choose to do if they want. And then ongoing staff training and resources. Signage. So having gender-neutral restrooms, kind of, this image on the left, I have people that are very close to me that face this kind of choice every day. Do I go into the women's room and get yelled at, or do I go into the men's room and get beat up? So looking at patient experience, I've been doing some work that I'll talk a little bit more about in a second around how to ask questions about sexual orientation and gender identity. But this is an example of an electronic health record that has places to identify sexual orientation, gender identity, organ inventory. And in terms of cancer screening, I, again, won't read all of these things, but these are some suggestions based on presence or absence of anatomy, hormonal exposure, and age for breast, cervical, endometrial, ovarian, and prostate cancer. And then this is actually a more updated, what I just shared was a summary of University of San Francisco recommendations from 2016, and this document from the American College of Radiology in 2021. I'm showing only 2 examples, but they have, I think, 8 or 9 vignettes of gender diverse patient scenarios and when you would provide mammography and when you wouldn't, and the considerations that you might take into account. In terms of trauma-informed physical exams, just focusing on minimizing medicalized trauma. So if they've had trauma in the past, not reinforcing that, optimizing safety, and also so often transgender men and individuals, cervical cancer screening, for example, has been very invasive. So the approval of the HPV kind of self-sampling is really encouraging for LGBT populations, but for people who have to undergo a physical exam, people with trauma histories may fear having their bodies touched. They might fear powerlessness, being alone with a provider, having something put into their bodies, having breathing or swallowing difficulties, or being unconscious. So what we can do about that is try to keep the locus of control with the patient, use shared decision-making, really explain a procedure before you do it, discuss potential modifications that can be made, validate any experiences of trauma, and acknowledge that history. So in order to give the patient as much control as possible, we can ask about priorities. We can describe what we're going to do, an overview of what can happen, and ask patients, what can I do to make you more comfortable? For shared decision-making, avoid exams that are not necessary. I kind of give the example, this wasn't an exam, but I was my gynecologist a few years ago. I went back this year and I told her, you made me take a pregnancy exam and I could have told you I wasn't pregnant. And that was an additional cost to me, right? Because it's part of the protocol, but it was impossible for me to be pregnant. So, avoiding things that are not actually necessary, considering less intrusive ways to get data, and using shared decision-making, especially when evidence is conflicting. An example of that is if someone is on hormone therapy and they have a diagnosis of breast cancer, having a conversation with the patient about the pros and cons of continuing hormonal therapy, and knowing that we have uncertain evidence, and some evidence is stronger than others, particularly if it's hormone receptor positive cancer, but having those conversations with the patient and being clear about what we know and what we don't know. This is an article that I wrote with some colleagues a couple of years ago, and it was trying to encourage researchers to include sexual orientation and gender identity in all research, because all research applies to us. And if we're not being asked, then we're being assumed that we're straight. Researchers are assuming and putting us in buckets that are not actually accurate. Other research strategies, using gender neutral language when possible and focusing on anatomy over pronouns. At my own institution, I'm trying to take a look at inclusion and exclusion criteria for our trials to make sure that we're not excluding people based on how we've always done things instead of what we're actually studying. So this is another study that I published this year with some colleagues. We took some recommendations from our National Academy of Sciences, Engineering, and Medicine, and we made some revisions for face validity. So our national academies was tasked with looking at past research and asking what's the best way to ask these questions based on what we've always done. But what we've always done hasn't always represented queer identities. And for example, one of the questions asked people to choose male, female, transgender. And so we revised questions to be more responsive to real life so that people could choose cisgender or transgender, man or woman, and have our sex constructs and our gender constructs appropriately named. So this was an article we published this year. And then we did some interviewing with individuals of different ages from different geographies in the US, because we have very different conservative locations or liberal locations, and political backgrounds, races, and ethnicities. And we basically asked 18 individuals, 9 of whom identified as LGBT and 9 of whom did not. Does this question make sense to you? Can you find yourself easily in the answer options? And then we made a few additional changes, which we're submitting for publication now. So I have a couple of case vignettes and just maybe 8 more slides, I think. But this is for a colleague of mine that I work often with, did these interviews and provided these. Charles came in, you can see his citation on the right there. He did these interviews with people with cancer who identified within the LGBT community. This white lesbian woman with breast cancer said, although my doctor knew all about me, each encounter with new people, with blood draws, ultrasound, breast x-ray, I had the basic anxiety of the procedure, and layered onto that the possibility of homophobia and having to watch out for myself. So this kind of shows you have this cancer-related psychological distress, and then on top of that, you have this fear of how you're going to be treated, which heightens that level of distress. Another lesbian with breast cancer said, when you're in that situation, you anticipate it because that's what you've known your whole life. You know, adversity, people not being nice to you. We discussed it, and she's like, it's probably not going to be a good experience. We're probably going to get looks. We might be asked questions like, why is she in here with you? Only family members can be in here. This gay man with colorectal cancer said, I had a Catholic priest come in and I had just found out that they didn't think I was going to make it. But this priest came in and he said, who's taking care of you? And I said, my husband. We've been together 32 years. And he says, that's a mortal sin. And I said, well, I love him. And then all of a sudden he said, I think I'm going to go. Maybe I can say a prayer for you. I felt I didn't know what to say because I was so sick. So key takeaways, having forms, both intake forms and electronic health records that include sexual orientation and gender identity, visual displays of acceptance, safety in disclosing sexual orientation and gender identity, culturally and clinically competent providers, and providers who are supportive of the patient's source of social support. Other things we can do, reflecting the language of patients when they, for name, pronouns, body parts, providing space to allow for a response, using open body language, following the patient's lead in terms of eye contact, looking up from your screen and being respectful, supportive, and professional. So really being professional is really kind of what this slide says. And then a study that I did last year, I interviewed radiation oncologists and radiologists around their experiences with transgender and intersex patients, which I didn't include a lot of information on for time, but I like ending my LGBT talks with this quotation from this gynecologist, because they said, I think in my role as a doctor and the team, that would also be to set the example for other staff as to what's appropriate, because setting ground rules as being the one who's asked the patient what they like, disseminating that information to other members of being an advocate for them or a champion for this type of practice in your setting. Because I think, going back to intersectionality, we all have some level of power somewhere, and we all have vulnerability in places. So where we can use our power to advance safety for other people, in clinical practice that is helpful. These are some resources that my team created a few years ago that include an I want you to know card, which asks patients about their name, their pronouns, any religious preferences, other information relevant to their care and caretaking. On the right are some strategies for providers to ask in terms of what to ask in phrasing for affirming care. And then we just wanted to have a poster that represented a number of common languages, as well as the rainbow, to make people feel included and welcome in the clinical setting. So these are available at the links at the bottom and have been downloaded by others. You can adapt them or use them as is, but those are free and available. And that is my contact information. So I'm happy to have a conversation about what feels relevant and what feels not as relevant, based on what I shared. So
Thank you so much.
and somehow we're still at time, and I thought usually I go pretty fast, but I was trying to speak slowly.
Bom, pessoal, professora, muito obrigado. Thank you so much. Alguém que está nos assistindo, gostaria de fazer alguma pergunta, fazer algum comentário para a professora Mandi? Se alguém quiser fazer, por favor, pode fazer no chat e a gente tenta repassar aqui para a professora Mandi, ok? Pode escrever, por favor, em português, que a gente repassa para ela aqui em inglês, ok? Bom, eu tenho uma pergunta. Posso fazer uma pergunta?
Claro.
Professora Mandi, a comunidade LGBT, ela tem uma grande vulnerabilidade para as ISTs e AIDS. Você tem alguma experiência, algum relato em relação à terapia antirretroviral e o tratamento quimioterápico do câncer? Há alguma implicação no uso simultâneo? Não sei se você consegue passar.
Vou tentar relembrar. Então, the LGBTQIA community has a huge vulnerability regarding the sexual transmission disease and
AIDS.
Yeah. Do you have any experience managing patients that have to deal with this treatment against HIV and cancer together, concomitant treatment? Do you have any experience on that?
Other colleagues of mine do have more experience. Since I'm on the health services research side and I'm not a physician, I wouldn't really want to speak to that, other than, knowledge of comorbidities. I know that, people who are living with HIV have a higher risk for anal cancer and head and neck cancers. So my knowledge is kind of about raising awareness to others around being aware of those risks and being aware of comorbidities. Another point this made me think of, even though it's not what you asked, for transgender individuals, there can be differences in chemotherapy effectiveness based on hormones and chromosome considerations. So my knowledge is kind of higher level in terms of raising awareness, but as a non-clinician, I don't have a direct experience to be able to answer that.
Okay. Thank you.
And in terms of the adherence, do you have the experience to navigate patients that have this comorbidity and that are under an active treatment for cancer? And there's ambivalence, and I know that they have to treat, but how to put everything together, and in terms of patient navigation, how to put patients to adhere all therapies. Do you have this experience?
I don't, and I talked to colleagues about LGBT-specific navigation, but to my knowledge, it's relatively new still. We definitely don't have a specific LGBT navigation program where I am. I think that's something that requires more work, but no, I don't have direct experience with that. Most of what I've kind of shared today are things that I try to talk with oncologists about or try to talk with nurses about to get out of this sense that it doesn't matter if you're LGBT, or I treat everybody the same, so I don't need to know. And that can get in the way of providing the care to patient needs, right? So I apologize, I don't have the clinical kind of experience. But this is kind of where we're at, is just kind of getting people on board with maybe it is relevant to ask these questions. So
I'd like to complete because here we have the patients that involve the situation. And in my experience, they can share the side effects with the another physician. And to solve this problem, just monitoring the effects like neutropenia more close. More closely than yes. And then we can, the patients take the two different vaccines at the same time. We just look a little bit more close the side effects, like neutropenia, thrombocytopenia, it's the name. Thrombocytopenia.
that's right.
Thrombocytopenia, yes, there you go. Almost the same word that I'm a little bit confusing. And the I mean, the blood cells is our the symptoms that we are a little bit more careful to deal in the management.
Biggest concern,
yes,
let's say.
Yes.
Is it?
Okay,
So now, Mandi,
so much.
I would like to go out about the clinical situations. I would like to ask you about what do you think about our health professionals about the new possibilities, because JMA journal published prostate cancer in women transgender. How you think? How do you think that we are professionals prepared about these new situations? Because we will have a new situations: transgenders for males, transgenders males with cancers, primary cancers about the sex. What do you think about our for preparation to receive this population? Because it's not easy, I think, because it's new for all. But what's your experience about it?
Yeah, I mean, I think for my part, I just kind of try to remind people that it's possible that a transgender woman might get prostate cancer. And while it's less likely if they are on estrogen, it's not impossible. And kind of PSA levels would now naturally be lower. I think that in my experience, healthcare professionals usually want to do a really good job. So once something's identified, maybe we could do a better job in terms of our communication, our reactions, our behaviors. But I don't think I've ever met a healthcare professional that wanted to do a bad job. And so I think for me, it's more about just letting people know to be open to, if there's an organ present, be aware that they're still at risk for that cancer if that organ is there. I think that in healthcare professional schools, that some schools are doing a better job of talking about these things. So I think that younger people coming into the workforce will have more comfort thinking about that. But I think right now, we need to try to share as much as we can with peers, because our population is smaller and we may not have a common experience of this, but it's hard when a patient feels like they have to continually educate their healthcare providers when they're going into care, right? So I don't know if that's helpful or not, but.
Yes. I think this is beginning for all.
Yes.
At the beginning of the process for all, even the patients, even for us, because it's a new. This article is this year.
Right. And I mean, I think it's important to remember too that the incidence of these things aren't new. We're just talking about them now. Right? So if we can't talk about things and share what we know and what we don't know, then care can't be better for the patient. And I know that a lot of people in the LGBT community just try to avoid care unless something's really, really, really wrong. And so I think, these situations have always been there, but we're just not talking about them.
Yes,
Right?
just start the conversation. Right?
Exactly.
Yeah, start the conversation. We have two questions from the audience. We have Professor Alexandre that he's welcome you to our university, and he is asking about what strategies in terms of training that are in place in your university to favor the inclusion of LGBT population. So what's the training in place for yourself? Yeah.
Yeah, so there's not great training, which is why actually I have, I was talking with, tomorrow morning, I have a grant going in next week for a curriculum to help improve healthcare professional training. Some of the content is, I mean, I abbreviated it, but I included some of it in this talk today, but it's longer and goes into more depth for each area. And I'm working with a medical oncologist, an advanced nurse practitioner, a couple of psychologists, primary care doctor. And we've piloted the training with good results, but it's not widely available. And I need support to kind of get that out there more. There are, the LGBT Cancer Network does have a welcoming spaces training that is online, and I think it's still free. It was free for a period of time. And so that's really more about non-clinical aspects of care. My training is trying to talk about both, as well as some policy considerations in the US. But I think some medical schools are doing a better job, and some are, I think students are increasingly demanding that schools do a better job, but we're still very early. You know, surprisingly, the University of Louisville in Kentucky has done an overhaul of their medical curriculum to really integrate this content in a strong way. I did my dissertation on this, so I kind of looked at, there was maybe 20 places in the world that were even trying to do a good job. And so that was a few years ago, but I think we're just really, you know, as with anything, there were leaders, and there are people that follow, and there's people that trail behind, and we're very much still on the early end of health education starting to address these things. So I'm trying to be part of that solution. The national, like I said, the National LGBT Cancer Network, Welcoming Spaces. The Fenway Institute in Boston has small webinars, small vignettes. And the University of California, San Francisco published primary care guidelines that included the cancer screening messages that I included from 2016, but I'm not sure how active they are now in terms of, and then there are some places like my friend at Mayo Clinic that are setting up transgender specific or LGBT specific clinics to focus on particular challenges. So we're in early days, I think.
And, okay, yeah, I have one more question for Ricardo. You remember?
Oh,
Ricardo?
yay! Welcome, thank you for joining us.
Yeah, I don't know if you have this information, but he's asking about the USA recommendation to treat trans male in terms of hormonal therapy for breast cancer in a adjuvant setting.
I don't know that
How to mitigate the effects in terms of returning, in terms of the male parasites come back because of the breast cancer treatment.
Yeah, I think that's where talking with the patient and making, talking about the risks and benefits of therapy. As again, I'm not a medical oncologist, so I would defer to my colleague, Dr. Cathcart-Rake at Mayo, who has specifically dealt with this issue. And I can try to follow up with you if you'd like, with what she might recommend. But from kind of an advocacy perspective,